Yes, following on from that, I'm going to talk to you from our experience as a company. Kheiron won a large award in 2020 to roll out, to build an evidence base to roll out an AI tool for breast screening. And we've been working on that project solidly since then. But there's a short extension, so we're due to finish in March of this 24. As you've heard, I'm the medical director of Kheiron Medical Technologies, so after that disclosure, I'm also the company's clinical safety officer in England. Provisions. This is to talk about data protection, but I'm a radiologist, I'm not an IG expert. These are my perspectives from our experiences over the 3-year project. I'm not going to get into the details of the legalities around the legislation, and I'm not here to challenge the positions of the ICO or any of the individual trusts we work with. Now, there's a lot of frustration about the data sharing arrangements in the UK at the moment. I think it's important to remember there's a story behind this. If I think about when I trained, we were handling often analog images, maybe digital print-offs. We would have packets of films for training, that sort of thing. I remember doing my exam in the old college in 2009, and we didn't have digital systems for that. So I would say that was relatively recently in the last 15 or 20 years. Suddenly then, digital imaging has come in very rapidly. And from there, we've gone from working at modality workstations into PACS in hospitals. The PACS have then gone through a change when the local service provider contracts came to an end in 2013, and trusts, maybe they did have PACS, maybe they didn't. If they didn't, they might have moved into another PACS, and then since then they may have moved into another PACS. There may be more than one PACS working side by side in the same organisation, and it's still commonly the case. Then there's been a move from the deployment to cloud-based infrastructures, and we've seen now what we're thinking about, okay, well, we've got all our human workflows, we've interpreted them into the digital world, and we're going to introduce some novel systems with AI. Particularly in England, much less so in Northern Ireland and Scotland, there's the challenge of what unique identifiers are, because maybe they're right for this system, but they're not right for that system, maybe they don't work in that hospital, whatever, and that's the backdrop. The next tier is, in that same period, and in reflection of those changes, we've seen the legal environment completely change with GDPR, followed by the UK legislation in 2018, and then trusts accessing confusing information that conflicts quite often, and I'll come back to that in a moment. And then everyone is on tenterhooks because there are media stories, Shipman, Patterson, people might go wrong because it rapidly gets high profile. We work in breast screenings, so I'm very conscious of the National Breast Screening Institute in 2018, and things where data sharing goes wrong, those things hit this press and make people very uncomfortable to take risks. This is an example of some information that a trust offered us in their understanding of data protection. It's very detailed, it's got a lot of information. Unfortunately, on closer inspection, although this came from an English trust, this is US legislation. So actually they're not even working in the same ballpark as everyone else. Okay, we've just heard the previous talk, thank you, about the differences between anonymous and pseudonymous information. And as we heard, if it's properly anonymous, it's not restricted by GDPR. There's also another level about who controls the data. In research, the expectation is the service sponsor controls the data. What we have found is that some trusts can inadvertently forget, maybe oversee when they're sharing data, that actually some of those data may be involved with other studies. So there may be inadvertent sharing. From a screening point of view, also, the local centres are the data controllers, but there's a more complicated relationship with NHS England, who also access the data and share it. So when you're thinking about sharing with third parties, there are other considerations. The key thing on this slide is that no two trusts are the same. The interpretation of legislation varies from trust to trust. That we've seen that there's this backdrop of risk, and you have varying risk appetites and then varying contracting frameworks. AI we're talking about massive data sets, much more than I could even fit in my training where I was training. We're talking about hundreds of thousands of cases moving weekly. So there's even a small risk. I think in screening, we're quite used to seeing too many people come to the program a year. We're comfortable with understanding a small risk has a big effect as the ripple goes further. I see data as the currency to achieve patient outcomes. I think there historically has been a desire to monetize that, but I think what you're buying when you're offering sharing of data is better outcomes for patients potentially. So I see the data as a currency. I see screening programs as very data rich, so they are good currency to use. In terms of the data protection impact assessments, these should be living documents. They're not the only living documents in the system, but they should be living. It's not just a one-stop shop. It's we understand this project and we understand how it's changing over time. They may cover lots of things depending on how the trust looks for what the trust is looking for in those DPIAs. I hear a lot of talk about, oh, we need to standardize these. Although the trusts are sovereign for their own data ownership, we need to standardize them across the country. I think that's a good idea. The problem we find is that every trust also has supplemental documentation from the IT team and maybe others from IG, other areas with lots of scientific or very pseudo-official names that you also have to complete. So I think even if you do standardize the template that everyone agrees with, the providers will still supplement it with more and perhaps more sophisticated documentation. Reality is real world data are messy. After they've been through that sausage machine of the story I told on the first slide, the data are in various places, in various quality. Maybe they're related to manual entry systems, which are very variable. So although the accuracy is a core principle of the GDPR, actually in the real world, that accuracy is not often borne out. Once you get your IG approvals in place, you've then got the problem of what format is in, can I move it? Generally, most health organisation data infrastructures are quite slow to move data about. So we'll come back to that for retrospective. But it's not always easy just to plug and play. That's very rarely the case. There are different perspectives on whether you're talking about retrospective data and prospective data. Either way, you've got to have a complete data set. You're talking about large data sets retrospectively. Those can be very slow to access. Thinking forwards, and this won't be any surprise to anyone, you've then got to think about the consenting issues about using those data particularly. There may also be third parties, so I might be plugging into a trust, relying on another system to drive the data flow in some way. As a supplier, we can only know what we know. We will process everything we get, but what we have found is we may not be getting everything because there may be a fault somewhere further up the stream. And we can't see that, we can't monitor that, and the trust couldn't see or monitor it either. So you have to make sure that your data flow is understood and being properly observed along the way. That can be an expensive and time-consuming problem. When you then get it plugged in, you've got the problem often, and I speak again from screening, there are often paper-based systems in place that you either have to adjust to different standard operating procedures or work around in some way. I'm going to say this is a very English slide. In England, we have the DTAC and we have the Data Coordination Board. The DTAC is supposed to be a standard that ensures that providers understand the project around them and the implications of that. The DCB 129 and 160, I'm involved with the 129 is on the supplier side. So I personally find this very helpful as a clinical safety officer. Perhaps less so because of the documentation, more so because it's a process that helps to ensure that there's someone else in the loop, the clinical safety officer at the provider side, who is giving an objective view and whom I can share my own concerns with fairly confidentially about what I think might be a problem at this particular site. And we can have that two-way exchange. And again, these are dynamic documents. So over time, we will update that, we will review our risks, and we'll make sure we understand, yes, this is how we thought it looked, or this is how it isn't how we expected. So what have we learned? Again, no two trusts are the same, so be prepared for that. Actually, paperwork and documentation are your friends. If you make sure you do those documents and agree those on all sides, then they will be helpful for understanding, because we're all aware that healthcare organisations have very rapid staff turnover. So having written down means that there's that continuity of understanding. Always expect the unexpected. You think everything looks the same, looks right at this trust, just a little bit at that trust, and then you get something else. And the key part of that is who's leading it on that side. Maybe you'll always need the clinical team involved, you'll always need the management team involved, you'll always need IG and IT. Different different members of those teams will be leading projects to a different extent. And so you might suddenly lose the resource from one of those teams at any point, and it might completely lose the project in that site. And we've certainly had sites that were really engaged and making really good progress, and then the clinical team has suddenly found unexpectedly lost resource, and we had to pull a project. And then be prepared that the interpretation of the legislation is very variable. Thank you.
Yes.